Thank you all for coming. My name is Craig Goergen. I'm an associate professor of biomedical engineering here at Purdue University. I also have an adjunct appointment in the School of Medicine at IU in surgery. And I'm thrilled to be part of the Women's Global Health Institute's day-to-day with some of the work that I'll be presenting supported by a pilot fund, both from CTSI and WGHI. So we are thrilled to be supported by this work. I'm going to move this down just a little bit. Want me to go over here? Is that better? Okay. So our lab does a lot of cardiovascular disease research. We're interested in hypertension, in heart disease, and vascular disease, which then led us to think about preeclampsia. So preeclampsia is a condition where pregnant women develop high blood pressure, protein in the urine, and a couple other things during pregnancy. And it's a really sensitive time both for mom and baby. And we're trying to think about technology, specifically wearable devices that can be used to not only predict or diagnose preeclampsia, but predict its development later on during gestation. So, and if we know that, what we can do to then prevent preeclampsia from even forming. Thank you. Okay, I'll stay away from the speaker and hopefully everybody can hear. And maybe we can. All right. So, preeclampsia, it's often silent until it's too late. 18% of preterm births and 3 million babies annually are due to the fact that we have preeclampsia in women. That means that mom is going to be at risk, but also the children start life at a disadvantage. There's about 14% of all maternal deaths worldwide are due to preeclampsia, and the current diagnostic metrics don't address risk very well, right? So not all expecting mothers are going to have access to treatment and care. But we do know that if we can diagnose and identify moms early in gestation, they're going to do better later on. So worldwide, right, 130 million babies every year and 2 million preterm births are due to preeclampsia. Just in the state of Indiana, the data today, the earlier sessions were better than this, but 82,000 babies in the state every year and 1,480 preeclampsia-induced preterm births. Means that it's an issue, right? The maternal health statistics in Indiana are pretty striking. It's a big financial toll as well. About $2 billion $2 billion every year from a healthcare perspective. State of Indiana, over 60 million. And then in some of these cases, right, where you have a really early baby, it can cost lots of money in the NICU. And so this is an average cost, but if you've got long NICU stays, it can be even more than $40,000. So our team, right, is filled with engineers, with clinicians, and with innovators. Several other graduate students are shown here. We've also partnered mostly with a clinical expert, David Reuter, who's an alum of Purdue, but now works as a pediatrician at Seattle Children's Hospital. George Wadika, who you heard this morning, has a lot of experience with innovation and device development, device translation. He's providing a lot of expertise in communication and in commercialization to the healthcare industry. And this is the fantastic team of researchers working with the women that we've identified, but also some of our preeclamptic rodent models that we're using to study the mechanistic disease. So the etiology, what's causing preeclampsia? In some ways, it's still not well known. We have an idea of what the metrics are for populations in general or what's happening in an individual patient, but we don't know in every mom who's going to develop preeclampsia and who isn't. Right, it's high blood pressure, it's protein in the urine, it's a central nervous system issue with seizures and headaches. And from the baby's perspective, the idea that all those things can lead to a bunch of problems in utero and then premature birth. And when you have a child being born at 22, 23, and 24 weeks, it's going to be a bad thing in general for not only in that early stage, but for the rest of their lives. Sometimes there's a placental issue. There's a lot of work being done in that space, looking at what's happening with placental blood flow. There's some immune response as well, some oxidative stress. But we're thinking and focused specifically on the hemodynamics to the kidney. And so if you can imagine this, right, if you're getting blood pressure measured, whether it's in the drugstore with a tube that goes around your arm or in the doctor's office, they can have you in a seated position, they could have you laying down on your back, but they don't often think about how blood pressure is affected as you lay on your side. And pregnant moms especially will tell you, right, that it's not comfortable to lay on their back for extended periods of time. What we're realizing, right, and thinking about all the way back from research shown in the 1970s, that blood pressure can be affected how we position the patient and what we're thinking about from a blood pressure perspective in relation to blood flow out of the kidney. So page kidney is a compartmental syndrome perspective where the blood flow is able to get into the kidney through the renal artery, but not out through the renal vein because of compression from the uterus onto that renal vein, leading to a bunch of problems in the kidney. So here's the mechanistic insight that we're trying to tease out. A woman could have renal vein compression on their back, but it restored flow on their side. If the uterus reaches the renal vein, typically about 24 weeks of gestation, resting on the back then can compress the renal vein and blood can get into the kidney but not out. So this can lead to blood pressure and a whole bunch of other problems. What we want to do now is measure blood pressure and body position at the same time with wearable technology. So an automated cuff that's ambulatory that can be worn on somebody as they are moving around or laying down without a bunch of wires, as well as a body position sensor. And that'll be then placed on the abdomen of the woman so that we know exactly how her torso is located, both either on her back or on her side, knowing that if there's a big increase in blood pressure as the woman moves from her side to her back, that's often predictive of preeclampsia later on in pregnancy. And knowing that change and identifying that change early on could lead to improved outcomes potentially for these women. So the thought is to develop a technology with these wearable approaches, with smartphones, with wearable blood pressure cuffs that can be done in the house, in an outpatient clinic, in sub-Saharan Africa or in India, right? In places where we don't need expensive clinical visits or expensive equipment, right? It's fewer trips to the physician, more time to proactively treat preeclampsia, healthier mothers and babies, and then hopefully peace of mind for these patients as well. We're thinking now from a mechanistic standpoint of trying to then combine this with blood tests and other approaches. The current techniques for diagnosing can often have poor predictive value. They don't address changes in pregnancy as the fetus grows and require these in-person visits. I know when my wife was going in for the regular blood pressure checks every 2 weeks and then every week at the end, right, it was really cumbersome to drive all the way across town for a quick blood pressure check. So if we could do that at home, we can increase, hopefully, positive predictive value and make it easier for these patients. Right, we're going to partner with those interested in maternal health to develop this solution. Right now, we've got a prototype for an app as well as devices for an ambulatory cuff and a body position sensor. The nice thing is that none of this is technology that's not available, right? This has all been out there and something that we know can happen. We've confirmed this mechanistic insight with some preclinical studies with mice. We've talked to some customers both from a patient perspective as well as maternal fetal medicine experts and done some confirmatory blood pressure studies in graduate students on campus here. So. We've filed some IP with the Office of Technology and Commercialization, along with David and George. Kirk Foster was on this patent that's now been granted by the USPTO. And we want partners. We like to connect with people in this room as well as across the states and elsewhere to help develop studies that we can really show to the clinical audience out there that yes, this is a simple approach, but it can be very powerful, right? We want to increase our positive predictive value and identify the mechanistic insights so that when we go to big clinical conferences, people will hear what we're saying and think about this for their own patients. So with that, we've got some studies coming up. We want to think about this with inpatients and outpatients, maybe even potentially do some blood work, some ultrasound to look at renal blood flow hemodynamics. We've established connections with people specifically at OB-GYN at University Hospital in Indianapolis, but are looking for other partners. And we'd like to generate some data for an NIH grant application. And specifically, NIBIB and others are putting out a small business SBIR grant award mechanism that will fund work into devices and technology that will be used to help pregnant moms in this early stage. So with that, I need to thank collaborators at Matter Health, at Parkview, others at School of Medicine. And with that, I'm going to leave it and happy to answer any questions if there's time. Sorry about the microphone issues.
Hi, I'm interested if y'all have explored how the predictive validity of this differs across pregnant people of different body sizes, just because we know that upper arm circumference can have an impact on the validity of those automated sensors.
Perfect. So the question is, how does this predictive test be influenced by patients with different body sizes. And so that is an absolutely important thing to focus on. And when we did our first studies, we're looking at height, weight, BMI on our patients as well, right? There's the patient weight at time of measurement, but also pre-pregnancy weights that we're trying to think about as well, because you will obviously gain weight during pregnancy. Another thought too, though, is that this could potentially affect anybody with large abdominal masses, obesity patients in general, without pregnancy, men and women. And think about renal flow obstruction in those patients as well. That won't be necessarily in a short term, but a much longer term. But I agree, right? We need to be looking at how those changes in blood pressure are measured due to uterine differences in growth, but also abdominal mass in general, especially in the obese patient populations that have poorer outcomes and are underserved already. So yeah, good point. Thank you for your question.
Any other questions?
Can you quickly hit on how the positional sensors work?
Hold on, Chris. They can't hear you online.
Just wondering if you could touch on how the positional sensors work.
Sure. So most people have smartphones in here, and as you pull your smartphone up, it turns on, right? It's a position sensor. It's detecting that you've now adjusted the position. It's the same idea with these inertial measurement units or gyroscopes, that we can use that same technology. You can buy ones pretty much off the shelf for $10, $20 that don't require a lot of external powering or a lot of other infrastructure. And they have Bluetooth technology. They can communicate with cell phones. And so it's more of a, because the technology is there, what from a pregnant patient perspective are we thinking about? So we want to make sure it's something that's unobtrusive, that a patient would wear. They don't have to have it on 24/7, but it might be something that they're going to be doing once a week, where maternity belts are common in later pregnancy. You can imagine incorporating it into those, but making sure that it's positioned correctly and then measures that change in body position. But I'm happy to tell you more, and we can talk about some of the technology later, too. All right. Thank you.
On to our next speaker.